For this video in the series on examination of the injured hand, we're going to be discussing examination of the extensor tendons. So when one is examining the extensors, it's important to remember the anatomy. So you can see, this young lady is allowing me to put some pen marks here. You can see you've got the long extensors to the fingers. And as it goes across here, you then have contributions from the lumbricals and the interossei, and it forms like a hood over the proximal phalanx. And this interestingly separates into three, and you've got one central bit that inserts into the base of the middle phalanx. This is called the central slip, and then you've got a little band on either side. Then it combines and it inserts onto the base of the distal phalanx. So one extensor, contributions from other muscles, and then it splits into three. That's a fairly complex sort of thing. Now, the long extensor is responsible for extension at the MCP joint. So if a person's got an injury to the hand and they're unable to extend at the metacarpophalangeal joint, they've injured the long extensor. If they're unable to extend at the middle phalanx, it means that they have injured the central slip. Now, interestingly, because of the combination of all of these together, you can have an injury to the central slip, but still be able to extend at the PIP joint, because you can have secondary pull from extending at the DIPJ. And the way to tell whether the central slip is injured when that scenario occurs is by doing the Elson's test, and we have a separate video because the Elson's test is a little bit more involved. If somebody has an injury to the central slip, they may get a Boutonier's deformity, which is an inability to extend at the PIPJ, and a hyperextension at the DIPJ, so compensatory. So the finger looks bent here and hyperextended here. Now, if somebody's got an injury to the extensor as it distal to the central slip, then they have an inability to extend at the DIPJ, and that is called a mallet finger. And the mallet finger is when you get a droop like that and you're unable to actively extend it. And when you have a mallet finger, you can have a compensatory situation with the proximal phalanx, which is a swan necking. Essentially, you have a droop here and you have a hyperextension here. But on an acute thing, you tend not to get the demonstration of the swan necking. So that, in a nutshell, is examination of the hand. In Elson's paper, he describes the test to be done by putting the hand on the edge of a table and keeping the PIPJ flex, and then checking the DIPJ to see if it's floppy or if they can extend it. That can be quite difficult to do in terms of the access, really. So this is a modification where you can get the patient's hand up like that, and you essentially flex and keep in flexion the PIPJ, and then ask the patient to try to extend the distal interphalangeal joint and see if it's floppy or if they can actually tighten it up. If the central slip is intact, then this will be floppy, okay, and they won't be able to extend it, right? If the central slip has been divided, they will be able to extend that, and this floppiness wouldn't be there. It will be a lot more tense, okay? Another modification is to actually get the patient to put your hands together. Let me do it from myself, actually. Another modification is to get the patient to put the two fingers like that. So you have flexion at the PIPJ, and get them to then try to push the two nails together. And if you have one side that is the central slip has been injured, they're able to extend a bit more, and you have an asymmetrical. So I'm pushing this to demonstrate what can happen. You can see you're symmetrical because neither of my central slips have been injured, and I cannot extend actively at the DIPJ once the PIPJ has been flexed.